Welcome everyone to today's webinar, How a Strong Workforce Management Strategy Became a Stabilizing Force at Sanford Health, sponsored by Simpler. I'm Morgan Hafner, editor with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Today, we are joined by Dr. Diana Berkland, Vice President of Nursing and Clinical Services at Sanford Health, Megan Goldammer, Chief Nursing Officer at Sanford Health, and Dr. Carleen Kerfoot, Chief Nursing Officer at API Healthcare and Simpler. At this time, I'm pleased to turn the floor over to Dr. Carleen Kerfoot to begin today's presentation.
Well, thank you so much. We are delighted that you are joining us today for this very exciting presentation. We know that this is really an important concept and an important part of our learning as we go through the COVID pandemic as well as other things. So we're really glad you're joining us today so we can all learn together. It's a wonderful opportunity to celebrate success in the middle of all this, and our colleagues from Sanford are definitely successful in being able to live with this COVID pandemic and be able to be better for it afterwards. We're very honored that they have decided to join us today. The whole point of what they're talking about is building resilience with a strong workforce management strategy. They're very keen on how this really has stabilized things for Sanford, both in terms of times of quiet and also times where it's absolute chaos. A big principle of what they've done and what we believe in at API is the principle of balanced outcome, that if you do something in one area, it will impact another. And we know that if you do something in the financial, clinical, staff engagement, patient satisfaction, and compliance area, it will affect another, both in times of quiet and also in times of chaos. We also know that cross-functional shared governance is exceptionally important. It's so necessary to get input and consensus from all key stakeholders, from nursing, from finance, from HR, from IT, from other patient care areas, to make sure that we can get the best information and the best outcomes, because we ask people what their best practices are and what their ideas are. It's also extremely important to include staff nurses in all the strategic planning, and you'll hear from our colleagues at Sanford about how they have a very strong shared governance structure there, not only at the executive level, but also at the staff level in nursing. You'll also hear about how important standardization of policies, processes, and technology is. As we think about enterprise-wide approaches, we really have to think about standardization of policies, processes, and technology across the entire enterprise so that we can move from one to another with standardized policies based on leading practices. And I'll also talk to you about how robust technology supports their culture and their strategy. I'll tell you about the power of integrated time and attendance and staffing and scheduling. Also about how to leverage analytics and also mobile technology. And they'll also talk about, how we all have to go beyond nursing to be able to develop a platform where everybody who's involved in patient care can look to the left and look to the right and know that they're doing the right thing in terms of staffing, scheduling, and outcomes for our patients. There's 4 things that you're going to hear today, which is based on what I've already discussed. And the first one is that even in challenging times, the healthcare system must have a workforce management strategy that has a balanced focus on finance, clinical, and staff outcomes. Number 2, culture. Leadership, shared governance, and data create the foundation for a strong workforce management strategy, and these people have got great examples of that. Robust technology needs to be the enabler to support the strategy and make things easier and not harder. And finally, a strong workforce management strategy creates throughout the enterprise a resilient organization that can successfully address planned challenges such as a magnet journey and unplanned challenges such as COVID-19 pandemic. So without further ado, let me turn this over to our colleagues from Sanford. And Megan, I think you're going to start, right?
Great, thanks, Carlene. This is Megan Goldammer from Sanford Health, and I'm joined here with Diana Birkland. We come to you from Sioux Falls, South Dakota, which is the corporate headquarters of Sanford Health. I'll just kind of introduce Sanford Health quick for those of you that aren't familiar with us. We are spread across North Dakota, South Dakota, Minnesota, and into a little bit of Iowa as well. We are a large integrated health system with $6.2 billion in annual revenue. We have 6 large medical centers, 40 critical access hospitals, over 210 clinic locations, and really span over 400,000 square miles. Sanford Health is comprised of nearly 50,000 employees with about 8,500 nurses, 1,500 physicians, employed physicians, and 1,200 employed APPs. We really have a truly integrated healthcare delivery system, including health plan, research, World Clinic operations as well. We operate our health services division in a very integrated fashion in our markets, as well as have a core central services division that comprises IT, HR, legal, finance, marketing. So that's really how we come together as a health system. Within the last almost 2 years now, we had our merger with the Evangelical Lutheran Good Samaritan Society. That brought us 158 skilled nursing and rehab sites across 24 different states, so significantly increased our footprint across the United States. We're really happy to be here today. We're really excited to talk with you all about a key nursing strategic priority of ours, and that was really around nursing workforce management. So I'm going to turn it over to Diana to start to kick off around really our success factors. And we like to say that was 80% culture of our organization and really 20% technology. So with that, I'll turn it over to Diana.
Thank you, Megan, and again, welcome. We're so glad that so many have been able to join us this afternoon as we share some of the learnings that we've had. So it's been our philosophy that technology should work for us, and in order for that to happen, it's very imperative that we have point-of-service staff involved in the design to the degree that the system can be designed and the governance of the new technologies. It's operationally imperative that if we're going to do this work, we have to have not only the right implementation, but it's got to be adoption. It's got to be about change management, about change leadership, and with all that within the context of the work environment. And that is really, I think, what defines a culture, that it is how it is that we adopt these technologies. Many of you probably have similar experiences to mine where we've invested in a technology, but the adoption was poor. So we've got the technology sitting on the shelf, but we've not used that technology to work for us. So that has been really, really imperative for us. To achieve this, there must be a commitment then to clarity of vision. That clarity of vision with a willingness to listen to the persons who are using this technology, because if there's not good adoption, we need to understand why that might be. And to hear those divergent perspectives. Not always do we enjoy hearing those perspectives, but those are really important that we do hear that, because that helps design the system in the manner in which it should be so that those workflow adoptions can be moved forward. And then it's important to have measurement and milestones along the way so that we know whether or not we've been successful, and then how we can give voice to those successes, because giving voice to that work actually provides energy and passion and commitment to the organization. So it really is a culture built on clarity of vision, having that clarity, and then trust and respect. The operating framework that we use is really around our values as an organization. So the values are really, really important to provide that framework for how it is that we're going to move forward. And then recognizing that everyone brings value to the table, and particularly for those of you that have gone through mergers and acquisitions, that merger and acquisition activity everyone has something important to bring to the table, and we need to recognize that, we need to hear that, we need to have dialogue around that, and then focus on that. So the clarity of vision, for me, it's very much about a nursing theoretical framework and how it is that I, as a leader, come to the table, and how it is that I can provide clarity of vision, something that our team members can commit to, that they can feel like they're part of that. And then recognizing whenever you bring forward a compelling vision, you're also you're willingly risking something because it might not be successful, and that's okay too. We know that there will be people who are laggards along the way who may not always want to adopt that work or integrate that into their workflows, and we need to be able to communicate with reverence and respect for those persons. So that's really from the philosophy that I bring to the leadership table, that's kind of my perspective on those things. We're going to go on to the next slide. So it's really been also built on a leadership accountability and a culture of cross-training. And when I say that, like I said, it's the cultural piece. It's who we are as an organization. And oftentimes I'll define culture as what happens at 2 o'clock in the morning when no one is watching me. That really defines for me what a culture is. So success is largely related to the operational implementation, as I said earlier, and the change management, change leadership adoptions that happen. Leaders need to have clarity around what are their expectations, what should they be held accountable for in terms of supporting the adoption at the unit level, at the departmental level, and what in my career, which has been quite lengthy, is that for the most part, nurses are not resistant to moving from department to department as long as we have provided them with the necessary training, skills, competency, so that they can feel that they can provide the kind of care that they want to provide to the various settings. So we really have a culture of moving nurses from point A to point B, moving across units and across departments, and that's really been done in a close partnership with our education and learning colleagues, because it really does provide the level of confidence and comfort that nurses need. We can go on to the next slide.
Diana, this is Megan. I would just add one thing onto that, really our culture and our vision around this, and that is that we as a management team, not just nursing leadership that we represent, but our HR leadership, finance leadership, data and analytics, everyone agreed that we really saw workforce as an investment and not an expense in our organization. And that's really the vision and that we needed to tell, and the story we needed to tell all the way down to the point of care, that this was going to be a balanced approach, and it wasn't going to be all about productivity, but we had to bring in the clinical outcomes in order to see this vision and this reality for us come to life. So I think that was important for us, that we all recognized that and really brought that culture forward when we started this.
Yes, and that could not be a truer statement, that it really is an investment that we see from the top of the organization on across the entire organization. We also are very committed to succession planning, and when we talk about succession planning, we're not just talking about succession planning between Megan and myself or other senior leaders in an organization, but it is a professional obligation that we hold as an organization. Again, part of our being, part of our culture, is that we owe it to the next generation, and if any of us something could change for us tomorrow, so we want to make sure that we have that very strong succession planning component. In fact, at Sanford, it is so strong that during our annual appraisals, performance appraisals, we are required to set forth several names in terms of people that we are grooming, that we're mentoring, that we're coaching, and providing that leadership for them. So that's really, really important for us in terms of succession planning.
I think it's what it allows to is us to continue the work. Many of our strategies are 3 to 5 year strategies, and if we're always succession planning and bringing those leaders along, there's never going to be a void, and you're bringing everyone along in the conversation, and your strategies and work can continue.
Yes, and I think that's a great example, because as I am in fact retiring, That's a great example because I was actually leading with Megan the workforce optimization work that we've been doing in the organization. And because of the way that we've structured this, it's going to continue without missing a beat because of that succession component that Megan just referenced.
I think we'll start to dive into a little bit of the why and how this became really a strategic priority of ours at Sanford Health. While you all know on the call, staffing challenges are nothing new to healthcare, we really are committed at Sanford Health to increasing our sophistication in how we tackle the issue. Sanford Health, really as an integrated health system, is about 10 years old, but we come multiple systems that have come together with long, rich, 100-year histories and valuable input. We really had to come to the table as we started to tackle this. We knew that integration was going to be key. We knew that we had to integrate both all of our cultures, our culture and our technology. We knew, as Diana mentioned earlier, that we needed to value the strength of each organization and the expertise that they brought forward in this. We had to listen with a willingness to be influenced in how we were going to go about this. But really the why for us, there were external pressures and internal pressures. And I think those external pressures that we all see out there is the continued demand for nurses and what some of the workforce projections look like, as well as facing retention challenges and really meeting our nurses and this new generation of nurses where they are. Staffing is foundational. We know that at our health system. It's really not about ratios so much as it is about the needs of our patients and the competencies of our nurses who are taking care of our patients. And we have to make sure that those match up right. And if they match up right, we knew that we could get the clinical outcomes that we wanted. So it's very, very important for us to focus on that and have the data and the subjective and objective data in order to kind of put together the art and science of staffing. And then we knew, obviously, evidence would inform our strategy, and this is really that balanced approach that we talked about at the beginning. It can't be all about productivity. We really needed to be looking at our other metrics around our clinical outcomes, our turnover, job satisfaction, and we knew with that the financial and operational outcomes would follow. So we were very, very key on setting up really a balanced scorecard of metrics as we moved forward in this. The opportunity internally at Sanford and kind of our compelling kind of burning platform was around some of these things that we list up on the screen. We are a magnet organization here at Sanford, and so through our practice environment surveys, we saw some areas of opportunity regarding staffing. We knew anecdotally that there was a lot of manager time being spent addressing gaps in schedules, some chronic over and under staffing. We knew that there were staff that were getting multiple texts every single day to try to cover shifts. We also knew that we had some non-standard incentive and pay practices. We knew that our API software, again, as kind of a merger of multiple organizations, we weren't all using it the same or in its most optimal fashion. We also knew that we wanted to reduce our agency staff and decrease our RN turnover. So these are just some of the compelling reasons that made us sit down and really come together as a team and say, we have to be more sophisticated around what we're doing. We can't look at reports two weeks in the rears to notice that we had a problem. We need to get more proactive and go upstream to start to solve some of our problems. So our objectives when we started this a little over a year or so ago, it's been, were really these three objectives. We said we wanted to optimize every unit, every facility, and every region. We wanted to standardize our staffing practices, procedures, and scheduling workflows, and we wanted to build a flexible workforce. I think that's become now really apparent for us as we know we need to have people that are trained to move across our organization and to fill our demands and what our patient needs are, and we need to give them the tools that they need in order to do that. So those were really our objectives going into the project. Again, there was really a balanced approach, and this really involved support all the way up to the executive level of the markets. We have market presidents that oversee all of our health services division, and they understood, as I said, that staffing is very challenging. It's an art and a science, but that we needed to help leaders with better tools to solve their challenges. So it really was very important for us to get buy-in and for them to help us talk about this vision we had all the way from our topmost leadership. On the screen here, you'll see some of our outcomes-based measurements that we have on a balanced scorecard and really what we're monitoring. I'm going to turn it over to Diana to talk a little bit about when we put the strategic plan together, we knew it wasn't just going to be about API and standardizing API, but in fact there were multiple prongs or work streams, and these are those work streams that we kind of put together to form our nursing workforce optimization. This was really our 12 to 18-month plan, and we'll continue to build upon this to get to our most optimal state. But this is really where we started and the different work streams, and I'll let Diana talk about those a little bit.
Right. So what you're going to see here is what we're trying to do is our optimization work is really an attempt to take the decisions from being made by guessing, kind of the what-if model that many of us have used over the course of our career, which is definitely what I was using in much of my career, to really optimizing decision-making based on sophisticated decision support tools, data that we are having. Like Megan said, you know, we're asking managers to do something, and it's 2 weeks in the arrears sometimes before they see data, which is not ideal. It would be much better if we could get into more predictive or even prescriptive ways of moving some of this work forward. So that was really a foundational component of what we wanted to do. So we started off with taking the technology that we had from API and making the technology work for us. We received data both internally and externally that took a look at how much time our managers were spending making corrections in the system, making scheduling changes, all of those kinds of things, and how could we structure that so that it was standardized across all regions and have everyone working off of a similar platform, recognizing that there may always be a need for some level of customization based on the size of the organization and the complexity of the services that they're delivered. So we call that kind of a mass customization approach to this work. An enterprise data analytics predictive modeling tool, and we have a very gifted team that works within our data analytics department where they're just brilliant men and women who know how to take data, know how to push it through some systems. They can do millions and millions of different models along the way, pulling in many, many different data points. That's something that would take any one of us as a human probably our entire lifetime to do, and they can accomplish some of these things within months. So taking that data analytics tool and doing some predictive modeling, and the predictive modeling can be based on things like what is the average daily census on a Tuesday morning, or what is it on the weekends. So you'll see seasonal variation. We as nurse leaders already know there's seasonal variation. Children's is a great example of seasonal variations. The fall and winter when people are trying to meet their deductibles on insurance, great example of surgical volume variation. So taking that, putting that beyond just what Diana remembers because of her lived experience, but actually putting that into a data analytics system. Taking the nursing position control grid, which is usually things around your budgeted FTEs, your actual FTEs, what do you need based on what the modeling is showing, which can really then help facilitate hiring and turnover, you can pull the turnover data into that. So we have a nursing position control grid where we have all of those data elements are brought into one place, so the manager can look in one place and see how they are compared to that. And then productivity, standardization, and comparative benchmarks. We are using ActionOI, which is really the foundation for anyone who is using staffing and productivity. ActionOI, it used to be called Solutions ActionOI. It's had various names over the course of my career, but it's really kind of the place to start for looking at how many hours you should have per patient day, or how many hours or minutes per procedure, those kinds of things, depending on which department you're talking about. Working very, very closely with our human resources partners, as well as the deans and directors of our colleges of nursing, to look at what is a recruitment strategy, what are we predicting for demand, what is the supply, and how is it that we can then work across the continuum to support that recruitment strategy. And then, as Megan referenced, kind of the balanced scorecard approach to this. And I'm going to turn it over to Megan. She's going to talk a little bit about kind of being from an infant all the way to a more mature adult process here.
Yeah, I think this is a longer play strategy for us, and I think we knew we needed to give ourselves time. So really, how do we get from our current state to a more mature state? We often said we were kind of in that kicking and crawling state in some of our regions. We were staffing to budget, some starting to staff to volume. We're really more interested in how do we get to the going from kicking and crawling to flying. And I think it's going to be through going upstream, getting more predictive tools in our hands, similar to how the financial tools that our organizations likely use to predict volumes and trends. So that was really our goal in kind of this maturity model. But we knew we had to give ourselves some time and start, but to start to move the needle.
As we look at some of the foundational beliefs around staffing and scheduling, I think we've all probably had this internal debate around should we staff to hours per patient day based on an average daily census. And, the flaws with that end up being that if you're going to be understaffed or you're going to be overstaffed. You're going to, have a shortage some days, you're going to be over on other days. And while the HPPD is an important measure and something that we really do care deeply about in terms of how it is we staff, there are other considerations that need to go into that discussion as well, including, what's your staffing model, what's your professional practice model, what are the skill and competence of your staff. And in my experience as a nurse executive for a large 550-bed tertiary medical center, what I often found that is, let's just say I needed 600 nurses. I had 600 nurses in the building, but it was often a maldistribution. So it wasn't always a shortage. At times it was, but it wasn't always a shortage of staff. It was a maldistribution of the registered nurses that I had. And that's where we really came about 15 years ago to say, we need to look at cross-training. We need to build flexibility into the workforce, and we needed it to do it in a way that honors the knowledge and skill and competence of the nurse so that they feel valued and respected in the process. And I talked a little bit about that earlier. That staffing is not just based on ratios. I'm not a fan of ratios. Some of you may be, but I believe that it makes sense to match the skill and competence of the nurse with the care needs of the patient. So a new grad will need to look different than an experienced or seasoned critical care nurse, for example. And then the work environment, how it is that our staff feel honored, respected, that their voices are heard, is so, so important. And we call our staffing and scheduling committee the Work-Life Balance Committee, because based on our experience, it really is your schedule and making sure that you feel like when you come to work, you're supported, you're heard. If there are care needs that are surfacing, that we have resources to bring to bear for that 2-hour time frame, for example. And then it really is a leadership accountability. And we have many young leaders, so we put together some leadership training sessions and things. One of the first things that we learned as we put together our leadership commons was our nurse managers really wanted to have some really strong information about finance. So we put together an online curriculum, worked with our finance partners, but also then I weighed in on that to put the nursing lens or clinical lens through that so that we were seeing it not just from the eyes of finance, but we were also seeing it from a clinical perspective. That was very, very important. So some of the 5 workforce management success factors that we have identified is that the manager of the department or the director of the department, whatever you may call that individual's role, is really the CEO of their department, of their unit. They hold the structural and functional accountability. They have fiduciary accountability for the budget in their area. They have quality accountability. They have people, their people, so the staff experience as well as patient experience. We need to make sure that they have the resources that they need to do the job and do it really, really well. And that means that we can't have just a one-size-fits-all. For example, an ortho unit on a weekend very likely will be very, very low in a census compared to maybe the labor and delivery unit, for example. So we can't just say everybody needs to do just X, Y, and Z. That the culture supports a cross-trained staff. And that is a cultural component. It's something that when you first start these conversations, they're not easy conversations, but that cross-training of staff. We call this our first, second, and third lines of defense, where the manager manages their staff on their unit. Then the second line of defense is really that cross-training component that we bring in, a central resource pool where we have local resource pools, and then finally the enterprise resource pool, which is like an internal travel agency, if you will, where these folks have been allocated the time they needed to feel comfortable, confident in the delivery of whatever services that we're asking them to provide, and then to make data-driven decisions supported by the data and availability of technology, how it is that we are adopting the technology into our day-to-day workflows. And then one of the challenges we identified with these data-driven decisions is our managers needed additional skill and training, educational opportunities in making meaning out of the data. So that's really been helpful for us. And I think the benefits that we're seeing come from this is hopefully we're going to see a lower cost with a better coverage to reduce the frequency of too many or not enough, kind of that wide variation of that we have seen. So we've seen that in some of our facilities. Again, we're kind of in the crawl walk stage right now in this work, but hopefully as we get to the fly, we will actually see that pan out to really reduce burnout and staff experience as well.
Just to kind of reframe in a different way for you, as you may be thinking about starting this journey, just those key components that we knew we had to have in place to really sustain this work. One was setting up the Workforce Governance Council. And this is really an interprofessional council with all those decision makers that had an investment in staffing and workforce at the table. So finance, nursing, payroll, informatics, human resources. We really had to get everybody to the table to make sure we could move forward in a standardized fashion. But I think what was also key was having someone at a high enough level directing this work, and we have actually implemented a coordinator that reported directly to the office of the Chief Nursing Officer, to my office, that really helps keep this work on track and kind of horizontally integrates the teams. So that was key for us to have that governance council in place. I mentioned before our C-suite involvement and other leadership teams to understand what the vision was, to understand where we were trying to go, and then to hold folks accountable to achieving the change in the metrics that we are looking for. We knew that we were going to have to really leverage and integrate all of our technologies. For those of you, I'm sure you have lots of different technologies out there, and we are in our early days of just totally going live on a Workday platform. We use API. We obviously have Epic as our medical record, Kaufman Hall on the finance side. So we really wanted to make sure that we brought our information technology partners and all of those teams together. So I think this will be part of the next 12 to 24 months, is how do we start integrating this robust data that we have everywhere to start to inform our staffing strategy. Because we know it's out there, and we have to have a plan for how we're going to integrate it. So that bringing those teams together early was key to start talking about that. And then finally, education for that director-manager level. Diana mentioned it. You know, we have hundreds of people in that director-manager supervisor level, and in order to sustain the work, we knew we were going to have to build this into their onboarding to make sure we're continuously educating on it and working at the elbow with them to make sure that they were implementing what we were putting in place for them. This next slide really kind of goes over the workforce governance a little bit more, so I won't touch on that. But we do take a lot of pride here at Sanford with our shared governance structure, and that really have a motto, nothing about me without me, and that really is about our frontline nurse, and they should really be directing their clinical practice and what they're doing as nurses. So through our shared governance structure, we've been really thankful that our frontline nurses have engaged, and our senates have engaged our governance on the nursing side in this, as well as our Nurse Executive Council, which at Sanford, really, that is just our nurse executives across all of our markets. We come together every single week. I lead the group, and we are really setting that strategy and vision for nursing at Sanford Health. So this council was key to make sure that we were having a very clear messages being given and brought down across our enterprise.
The workforce management strategy that we have is really important, and it's really founded, again, like Megan said, on nothing about me without me philosophy, which really is very consistent with the shared governance model that we have. We have two of our hospitals that have achieved their third and fourth magnet designations. And you'll see on here some of the outcomes, which aren't unusual for magnet organizations to experience those things. So you'll see that on here. And then I would just want to highlight here the attributes that I think are so important for success in all of these things. And it really begins with a transformational leader who embraces the structural empowerment to support the exemplary professional practice, which compels leaders to implement the robust workforce management strategies that we talked about. So it's about that compelling vision, because if I look behind me and there's no followers, I really am not a leader, and that's really where I think the transformational leadership, it becomes such an important component to that work. And I think I'll just go on here, and Megan can talk about technology again.
Perfect. You know, as we wrap up our last couple slides, I think we spent a majority of this really talking about the leadership and culture and having that compelling vision around the strategy. Just quickly to touch on the technology, you know, we always here at Sanford believe you can't lead with technology to solve your problems. Technology should complement the structure and goals and objectives that you're trying to achieve. So that was really important for us. And quite honestly, we probably started our journey when in some of our facilities years ago when we got on API with thinking that technology was going to solve that problem for us. And so I think it's important to make sure you kind of switch that around and really overlay the technology over the vision you're trying to create. So I won't spend a lot of time there. I think we all understand that. You know, as Diana mentioned, having a strong workforce management strategy helps achieve your goal for us during the good times, like our magnet journey, but also can be a stabilizing force during times of crisis. And we thought we'd touch quick, because we are in the middle of COVID-19, on what some of our experience has been during this time. It's probably important to note that we do, our Sanford footprint exists in the area of a couple meat packing plants that made national news. We were at the epicenter at one, Smithfield, if you've heard of it, meatpacking plant in Sioux Falls, as well as JBS in a town about 40 miles away. So we definitely experienced a surge and had to really plan for the worst was our motto. and I'm proud to say we were ready. But I think having our clear vision and having components of our workforce strategy in place really helped us during this time. Diana mentioned those lines of defense. When we get in a time of a short or a crisis time, we don't want to have to just automatically pick up the phone and call for travelers or call for agency staff. We want to make sure we have key lines of defense in place. And those are our routine staffing plans on the unit being the first line, the second line being cross-trained float pools internally within our medical centers, our third line being our external. We have an enterprise-wide float, really external travel agency of our own Sanford nurses that can go across our system. And so that really gave us the flexibility to ensure that we had a lot of qualified staff where we needed them. I think another proud moment for us during this is that we never had to consider furloughing any of our employees during this time. And in fact, we really used it as an opportunity, thanks to our HR strategic partners and our education team. Really, we were able to use that time to upskill and provide additional training to a lot of our ambulatory staff when our clinics had to be closed, preparing them to become medical surgical nurses and preparing our medical surgical nurses to become ICU nurses. And I think the culture that we have around, we'll give you the training, we'll give you the tools, really made our staff feel comfortable and, in fact, raised their hand to say, we'll help where we're needed, because they knew they were going to get the support they needed. So, at the beginning we said that our ultimate goal was an outcomes-driven workforce optimization strategy. We knew it was our job to create that environment in which people can do their work that they were called to do, and that they could accomplish that. So I'm really proud of our teams, really our entire organization coming together around this, because it really has been a group effort to get upstream to solve our issues. But we knew if we came together as an integrated health system, we knew we could be really transformational. So while we're just in our first phase of this work, hopefully we'll be back. We have to give some of this stuff time, but hopefully we can be back in a year or so reporting on some really successful outcomes on this. So with that, I'm going to turn it back over to Carlene, I believe, to give some closing comments. And I know we have some time for questions, too.
Right. Thank you very much for that excellent presentation. We're really able to look at the big picture and how you've been able to operationalize those two people are really great. Thank you so much. And now it is time for questions and answers. So you can submit your questions by typing them into the Q&A box that you see on the screen. Let me start with the first question here. The first question is, can you talk more about the relationship between nursing and finance? For example, how involved is your CFO with your workforce management strategy? And how is finance involved with helping nurse managers be the CEO of their unit? Would you help us with that question?
Yes, this is Diana. I'm happy to answer that question. I recognized years ago as a nurse executive that I really needed to have a close partnership with finance. And it's something that as nurses we may not always just intuitively come to understand how it is that the finance comes as part of this work. So as we started our workforce optimization work streams, we actually had two of our CFOs from two of our markets who sat on the committee or are still sitting on the committee with us as we have those conversations. And what happens is there's a tremendous amount of co-learning that happens. The finance officers learn from the clinical perspective and the clinicians learn from finance. So it becomes very much around some of the foundational things about mutual valuing, trust, and respect that you heard us open with here today. So they actually are instrumental in sitting on the committee. So they're there every day. It's an open group so that if all the CFOs choose to be a part of it, and some of them have, but there are two standing members that are always in the room with us. The other thing is in terms of the training or development, the leadership commons that you heard us reference, we actually worked with our directors of finance to establish what their perspective on the curriculum would be. And then, so what we did is we asked finance to sit down and put together a beginning curriculum for what nurse managers should know. Then we ran it through me because I needed to help put it in the language that I knew would be translatable for our frontline nurses. That actually has been one of our frontline nurse leaders, I should say. That has been one of the most popular curriculums through our Leadership Commons because of the fact that we embedded both finance and the clinical perspective in that work. Did that answer the question?
Sounds good. That's good. Let me ask you another one. Thank you for sharing this great overview of Sanford and the work you are doing. Can you please share more on your education strategy and beyond nursing clinical degrees? Have you identified other critical learning or skill gap areas that education partners are able to support?
My question is, are we talking about the cross-training part of it, or are we talking about the nurse manager? Because I have a different answer depending on.
Why don't you just give us both? That would work.
Yeah, so from the cross-training component, if the question is around cross-training, that really is working with our education and development partners, and we have what we call pathways, like a pathway for them. So as we're cross-training people, if I am going from critical care to med-surg or vice versa, I have a pathway that I follow. And it's pretty common in the industry to do things like this. So that's really how we have addressed the cross-training. We give them a very similar training as we would if I were going to be working in that unit permanently. So that's a piece of that. And we find that there's foundational skills that are the same regardless of which, blood pressure is a blood pressure. So those kinds of things. If you're talking about the leadership development piece, what we have done is we actually have onboarding training that we do for our all new leaders and managers, and finance is a part of that. They'll sit down with them on their to review their budgets, how to do a budget, all of those things. That all happens in a one-on-one as well.
Yeah, I would just add, it's we continue to find opportunity. I think in the abundance of information we have, and we're always kind of re-looking at what are the key tools that we want these frontline managers to be using. When we've done inventories, some unit managers might be downloading 50 different reports to try to manage, everything from their physicians to their nurses to their patients. We're really working towards, like I said, combining a lot of our data systems to draw and then use our EDA team to really build a customized dashboard and really we call it a balanced scorecard. Because we know that many of these factors, if you have to look at them in a balanced way because they affect each other. So we aren't quite where we want to be yet, but we know where we know what that looks like. And I think it's just as we implement new technologies and get better defined around the information we want those frontline leaders to be looking at, we're continuing to refine that.
One of the tools that we're using is a tool called Power BI, which I can get on my phone. So there are apps so it makes it very, again, to the mobile component of this technology, it really makes it very easy then for the manager to look at his or her dashboard right on his or her mobile device.
Good. Here's another question. Despite not seeing nursing as an expense, how do you see your organization's cultural structure leveraging this asset? Can nursing be turned into a revenue source versus an expense?
Absolutely. I mean, I think, we've really grounded ourselves on really the principles of what an elite nursing practice looks like. We touched on some of those around our shared governance, our care delivery model, our professional practice model. And, I was just in front of all of our nursing senators and our governance team a couple weeks ago, and I think nurses in the future have really the ability to go from the most trusted profession, as we have been the last 18 years or so, to really the most influential. And when I say that, I mean influential in how are we changing the healthcare delivery model? How are we utilizing nurses in a way that helps us take even better care of our patients, in the right setting, as we all are moving towards that value proposition and really value contracts? So I think if I look at our organizational strategies at Sanford, almost all of them involve some component of nursing, and how that nursing is not only helping us to achieve better clinical outcomes, but better value. We really talk about it in the sense of value for our patients.
I think in addition to what Megan is saying, and it's really adding on to that, is if we give voice to the work, which is where we've often struggled as a profession, is really being able to clearly articulate the value that nursing brings to the table. And I think that's where these scorecards, these dashboards, we can begin to quantify that both subjectively and objectively.
I think maybe two really good examples that are on our horizon that many of you are probably looking at is we started a COVID home monitoring program, and it was really a way for us to take better care of our COVID patients that have just been given, they've been told they have COVID and they need to go home and quarantine. They're not sick enough to be in the hospital, but we knew that we wanted to be able to, for certain populations, more closely monitor them. So we really leveraged our nurses, and that's really kind of, I would say we want to continue that monitoring strategy and really make it more robust in chronic disease management. I think that's just an example of how we use nursing to take better care, but also at a better value for our patients. Hospital at home programs, many of you are probably looking at that. How do we take care of certain DRGs in the comfort of people's own home versus in an inpatient hospital stay? And I think that drives potentially better revenue, but also maybe better care too for that patient.
Here's another question about how you optimize staffing to meet patient needs in a situation where you have the majority of nursing staff with very little or no experience.
Yeah, I think, when I think about staffing, and that is a challenge when you have lots of new graduates, and it's, you're not going to end up in like an Action OI 25th percentile for staffing, because when you think about it's having adequate numbers of qualified staff. Well, that depends. The qualified staff depends on the experience, the skill, the competency, the infrastructure that you have in place to surround the nurse as well. So what's the role of the respiratory therapist? What's the role of the rapid response team if you have one, the PT, the OT, the social workers, all those other disciplines? And it's easier to talk about than it is to actually accomplish, but it's that infrastructure that surrounds the new graduate and how it is that if you do have a great experienced nurse, how it is that you can use he or she to help mentor and coach those folks. And I say that oftentimes what I needed when I was working at the bedside in my critical care days was I needed someone who could complete many of the psychomotor skills, emptying the Foley catheter, checking the blood pressure, bringing those things to me then as the charge nurse at the time, because I had all new staff that I was working with. So then I could kind of stand at the intersection and guide and direct people. So I don't know if that really answers the question. It is complex, but I think that's where you really have to be creative and invite the people who are part of that work to be part of the solution and help you get those things figured out.
Good. Here's another question. Did you introduce any system functionalities in API Healthcare to support the COVID unit?
No, we did not.
Okay. This one is, I am a nursing manager and wonder if you allow managers to make staffing decisions.
Yes, managers make staffing decisions all the time. The structure depends again on your system of care, your care delivery system. If you have charge nurses in our organization, we call them clinical care leaders. They really are empowered to make those decisions based on, what they know the care needs of the patient are, the skill set of the nurse. But the manager is obviously, as the CEO of his or her department, really does need to be involved in those staffing decisions too, because things will need to be run up the flagpole, so to speak. So if I need help as a clinical care leader or charge nurse, how is it that I reach out to that manager? So I think absolutely the manager has to be involved.
Okay, and one more. Can you give an example of the dashboard components that you use?
The nursing workforce dashboard, I think right now we're really toying with what are those key leading and lagging indicators that we want. We have turnover. We have quality outcomes. We have patient experience. We have staff experience. We have, I'm trying to think what other ones we've been looking at premiums and overtime pay. What other ones? We've been really toying around with our financial metrics and looking at hours per patient day as a percentage of net operating revenue. So those are some of them, and really we're trying to kind of get them in front of our leaders and then build kind of what's the view look like at the chief nursing officer level, what's the view look like at the executive director level, the nurse manager level. So it's really in its infancy right now.
Okay, one more, and then we'll draw a close to this, and thank you. The next one is, do your organization choose a centralized or decentralized model for creating schedules? What about filling open shifts?
Sure. We utilize self-scheduling across the majority of our system at Sanford. So we really have our staffing grids that identify where the needs are. Our nurses come and really self-schedule in. We then, where we need to, where all if the shifts aren't all filled, we have really more of a centralized model then to work on plugging in to make sure we have all of our needs met. We use texting as an option for open shifts, but we are currently ready to bring live mobile time management through API, so we're really excited about that. And continuing to look at new and innovative ways of how people want to grab shifts, almost kind of the Uber model, if you will.
That's good. Well, let me sincerely send our appreciation to both of you and to your whole organization for being able to put on such an innovative and informative webinar. We really appreciate all the work that this represents, and we know you've been at it for many years, and boy, it really shows. You have lots and lots of leading practices that we can learn from. And as a reminder, when we started, we said that, workforce management strategy is really important, and it's really important to have those balanced outcomes that we want in terms of finance, clinical, and staff, and you've certainly got many examples of that. You also talked about culture, leadership, and shared governance and data, and we certainly learned a lot about how you leverage shared governance both on the executive level as well as the patient care level. You were very articulate about the third one that we talked about, which is that technology is an enabler that supports the strategy and makes things easier and not harder. And you also strongly talked about, workforce management strategy that creates an organization that can successfully address change, such as a magnet journey, and also unplanned change, such as COVID-19 pandemic and anything else that's going to happen. So thank you so much for your very diligent work that this represents, and for being willing to answer questions and share all your information. Thank you very much, and I'll turn this back over so we can finish the program.
Thanks, everyone, for joining. We appreciate it.
And Becker's wants to thank Dr. Berklin, Megan, and Dr. Kerfoot for their insightful presentation today, and Simpler for sponsoring today's webinar. Of course, thanks to our audience as well for joining us. We invite you to join us for the next webinar on September 24th on how Advocate Aurora Health builds resilience with a workforce management strategy. You can register by clicking the link under your resources section. It's located on the right of your screen. Thank you again, and we look forward to having you join us for future webinars.